Good afternoon. So today, we're talking about Bundibugyo, the jungles spillover to global concern. So we start in 1967 in two labs in actually in Europe, one in Marburg in Germany and the other Belgrade in Serbia. And there's two teams of researchers who are working with African green monkeys, which are capable non-human primates on the left. And the lab, but in both cases, these lab workers and lethal ill. And this is the start of our journey with Marburg virus. And I wanted to just start with this because we are talking about Ebola viruses today, but they are very, very closely linked. And you'll see they share quite a lot of similarities. One is how they present, how they get transmitted, but also we'll have going to be talking a lot about non-human primates today. So in 1967, we had Marburg virus, but currently we have 4 Ebola viruses that are found in humans. They are named after the places where they were first discovered. So Thai forest, there's only been one case of that ever recorded, and that's in the Ivory Coast. Then we're talking about Bundibugyo, which is in the western part of Uganda. The Ebola virus, which is called the Ebola virus Zairense. So that's the old name for the DRC Congo is Zaire, and Ebola is the river that it was first found here, and the Sudan virus. So there are 2 others, the Bombali and Reston, which are not actually found in humans, as far as we know. The Bombali has only been discovered in a certain bat, and the Reston has been described. It was found in a lab in Virginia, Reston, but is actually linked to pigs and planes. And then, as you said, the close clinical cousins of the viruses. So in terms of how these viruses spread, and here the main reservoir of these viruses are the bats. There's 3 different types of African fruit bats, and along with which are harbor these viruses, but are actually not affected by them at all. And along with their saliva, urine, feces, they can contaminate fruits and other things that they touch. And then normally in the jungle environment, the non-human primates eat them and these fruits, and then they fall ill. Humans will then either fall ill by being in contact with the monkeys, either through eating bushmeat or even through direct contact with the that saliva from the fruit themselves, if you're not washing carefully. And then there is potential for spread between humans through direct contact with bodily fluids as well. So if you even, I think, ask any layperson what is their example of a viral hemorrhagic fever, I think the name Ebola will come up. And this is from the CDC website, and that gives you a very good idea of how the clinical staging goes. So initially there is an incubation period that can last 21 days, followed by a dry phase, which is prominent fever and myalgic symptoms, and followed by what is termed a wet phase of GIT symptoms, which predominate with diarrhea, nausea, vomiting, and bleeding, but so quite later on in the disease process. And what's interesting, as you can see from the bottom, is that initially the patient who's in the prodromal phase is actually not very infectious. But the closer they come to the wet phase and towards the end of the patient, the closer they come to that is when they are most contagious, because they have a high amount of circulating viruses in them. And these are, I think, really nice pictures from the Republic of Uganda's Ministry of Health. This picture on the left is actually from their Instagram site, which has really clear pictures of signs and symptoms, along with the number for contact tracing or to report any cases, and also how Ebola virus spreads. So keeping, once again, along with blood, it's very interesting that it's spread mostly through vomit. The highest number of amount of spread is through vomit and feces. So you can imagine that people who are looking after patients who are infected, they're incredibly high risk, family members, and healthcare workers who are probably not very appropriate if they're not aware of the diagnosis. And even if they do, patients survive, there are long-term sequelae. And this is from the original Bundibugyo outbreak in 2007, when they looked back on these patients a year later. There were a higher risk of hearing loss, twice as likely to have hearing loss, and 6 times more likely to have memory problems and confusion, preventing them from returning to the work that they were doing previously. And I mean, it's sort of very similar to the post-COVID brain fog or the post-dengue viral syndromes that we have seen of the viruses. So this is all the Ebola virus outbreaks since first recorded one in 1976. Bundibugyo comes quite late in 2007, and it's actually not one of the common virus types that have actually caused outbreaks. This is actually only the second major outbreak. The most serious outbreak was the one in the West African Ebola outbreak from 2013 to 2016, where close to 30,000 people were confirmed cases, but it is estimated that around 10 patients will be affected by it, with a mortality rate that was close to 50%. And that's focused on Sierra Leone, Guinea, and Liberia as the 3 most heavily affected countries. And that's just a map on the left-hand side showing you all the different areas that were affected. So the 2013 outbreak of Ebola in the West Africa really spurred a global reaction. Not only were there patients outside of Africa involved, there were 27 patients around the world, mostly in the US and Europe. And you can see there were people, some of them were medically evacuated there. Others, there was a limited outbreak because travelers went from West Africa to the US and to Spain, where they later became ill. But this also prompted the medical community to actually try and put together both therapeutics and vaccinations in place to help contain such a rapidly progressing outbreak. And between 2014 and 2019, there was a huge push to have vaccinations, to put research and to accelerate what is already there. And it is thought that this is actually what allowed us to have such a good and quick turnover in the COVID period, because some of the research was already done, some of those technologies are already advanced. So what is available for therapeutics for this Ebola virus at the moment? We have 2 monoclonal antibodies which have been registered. So the first one is, the trade name is Inmazev, which is a combination of 3 different monoclonal antibodies that target different sites of the Ebola glycoprotein. And the other one is the trade name is Ibanga, and the actual name is Ansubima, which is derived from a survivor of the 1995 Ebola outbreak, so it's a survivor-derived antibody. And these were tested in the 2018 to 2020 outbreak, and against the best available therapy at that time, which was supported care, and a mouse monoclonal antibody called ZMapp, which was thought to be the most likely candidate at that point. And those who had received both, so Regen EB3 is the Inzimab, and the MAB114 is Ibaka. Both of those did far better, so it was about 17% or 18%, 17.8% more likelihood of survival if you use these new products compared to the old ones. And this trial was called PALM trial. And we also have 2 vaccines that were trialed at the same time. And the vaccine here is a vesicular stomatitis virus, which is the carrier. And with it leaves the Ebola virus with it. And this is a live attenuated vaccine. It's highly immunogenic. So within 8 to 10 days of having your single immunization, single injection, you have appreciable antibodies. And they gave 300,000 contacts patients between 2018 and 2020. And it is estimated that the effectiveness was 97%. This going to help really control that outbreak. The only downside is that it requires cold chain for storage. There is another vaccine that is available. It is a adenovirus based vaccine, but it comes in 2 parts, so it cannot be used in an outbreak situation. So the first part is an adenovirus with Ebola virus inside, and it's 8 weeks later, you get a second portion, which is a different vaccine virus carrier, which is a modified Neisseria enterovirus. And in that, there's 3 different types of viral emergent proteins, so Ebola, Sudan, Marburg, and Thai forest. And the idea here is that you can't use it in an outbreak setting because it takes 8 weeks. However, if you give it to healthcare workers, for example, people in high endemic settings, that you will sort of give them immunity going forward, and so that they are less likely to fall ill. We, however, do not know how long the immunity will last and how many boosters they will actually have. It is estimated that it will be about 1.5 to 2 years. And the 700 odd healthcare workers they did try it on, everyone did have a response. However, we also don't know how to interpret the antibody titers and how many titers you put. What is a good number for you to have to prevent infection? Which brings us to the current outbreak in Bundibugyo, which was declared an outbreak on the 7th of May 2026. And these started on the east coast of the Democratic Republic of Congo, and it does mostly fall into the DRC, the parts of the western Uganda are also implicated. And on day 0 of the outbreak, the International Pandemic Preparedness Secretariat has a very pretty but rather depressing statement that unfortunately for Bundibugyo right now, there are no approved point-of-care diagnostics, there are no approved therapeutics, and there's no vaccines available. But what are some of the options that we can look at? So in terms of therapeutics, there are 2 monoclonal antibodies that are being looked at and are going to be trialed. So one is the NDP-134, which is a mixture of 2 monoclonal antibodies, once again from 2 different survivors. One of those antibodies has been advanced to cover more epitopes. And this is the most clinically advanced antibodies. It was used in a different outbreak in the Sudan virus in 2022. The advantage is it's a single dose, so patients don't have to have in getting doses. The other one is a monoclonal antibody called Miftirimab. This is the most potent neutralizing antibody in the set, which was a combination of 3. So we're sort of reusing that one to try it. In terms of antivirals, we've got remdesivir, which is a very broad antiviral. It's an RNA-dependent RNA polymerase, which causes chain termination viral. And we know it well from COVID-19, has repurposed them. We might also say that it was also used in the PALM trial and it didn't do that well. So why would we reuse it for Bundibugyo? Well, in vitro, it is much more active against Bundibugyo than it was against the virus. And in rhesus macaque monkeys, the addition of, for example, a monoclonal antibody with MVP134 and remdesivir together had an 80% survival rate for monkeys, and that is far more than either of those components alone. So we are trying. Then there's also a Baldessivir, so trialed in COVID-19 as outpatient therapy. The advantage is actually an oral form. It gets converted to remdesivir in vivo. And the hope is that you could use it for pain and give it to patients to take home, and at least you don't have to have contact. And hopefully people will actually take it because it's just an oral tablet and try and bedspread. So just in some considerations on monoclonal antibodies, if you use a single monoclonal antibody type, there's a risk of viral escape because you only cover one part. That virus isn't expressing that the encode that you are covering going to have viral escape. So to cover that, what you give people a cocktail of monoclonal antibodies to cover all these different pictures, complementary mechanisms of action to try and see that you can't get all the virus. There are also concerns of risk for mutations, rendering these monoclonal antibodies ineffective. And the question is, for example, in patients with Ebola, we know that there are sanctuary sites in, for example, the sperm or a brain and iron fluid. So when these patients have recrudescence or viral systems, and then be treated with these monoclonal antibodies, what does that mean in terms of effectiveness? They are actually also monitoring to see if there are, because there is natural, obviously, mutations of the virus and whether they are, whether they will become naturally resistant to these ones. The vaccine, so in terms of vaccine development, so there are 3 that are being prioritized by the World Health Organization. And so the first one is once again a vesicular stomatitis virus, which I'll go into just now, but it's the closest to clinical trials there, but they're still about 7 to 9 months away. Then the Oxford University Serum Institute of India say that they are 2 to 3 months away from clinical trial, but with a 1-dose formulation or a post-exposure prophylaxis and a 2-dose for more long-term immunity, but we will chat about that. Then there's a idea that maybe the Ebola vaccine that we used for the Ebola virus might offer some cross protection. It is unclear whether that would be true and how much would actually be offered by them. So the vesicular stomatitis virus called Bundibugyo was actually developed already, well, partially developed and had rhesus monkeys trials in 2013. So this is soon after the original 2007 outbreak. And what you see here is that they had spirit monkeys in 4 groups. And what they did is they gave one monkey just no vaccine and just gave them Bundibugyo. And unfortunately, 2 of them actually died and 1 survived. They gave three of them vaccine and all of them survived. And then they gave the other 2 groups of 3 different variations of the vaccine, so with different mixtures of so Bundibugyo plus Ebola or anti-forest, and to see if having different antigens actually did offer some sort of cross-reactivity and if boosting that would actually help. And they also did try use this as post-exposure prophylaxis, and it does show that with those who had received a vaccine within about 20 minutes of being infected with the virus, more than 80% of them.
With everybody who's involved, everybody who has exposed to the virus
in 20 minutes,
20 minutes.
You're ready to have your first exposure. It's a unfortunately monkey model as well. So
there's nothing wrong with the monkey model. It's wrong with the time.
Yeah. So the other is the adenovirus vector for the Oxford Institute. And they have used this for Rift Valley fever. So they're hoping that they can change the antigen basically to change that to Ebola Bundibugyo. But there is no animal data yet on this. But obviously we have extensive COVID-19 experience. So lastly, I want to just talk about what about supportive care in terms of the sort of hemorrhagic fever. There's a lot of GIT issues, there's a lot of dehydration, a lot of electrolyte abnormalities. And what we wanted to bring, I thought this was actually quite interesting, is that there's the 27 patients who were not treated inside Africa for the 2013 to 2016 outbreak. Yes, well, this was published in the NEJM, and they had a 82% almost survival rate compared to a 60% survival rate for those who stay in Africa. And they wanted the attention that these patients had very, very intensive supportive care. They had ventilation when they needed it. They had renal replacement when they needed it. So I think there's two ways you can see it. It's either that the disease is so severe that even with the best supportive management, and I think just about every single person had a experimental drug as well, there was still a 20% mortality rate, or that actually with the best supportive care you can actually increase that survival rate by significantly. And to contrast, and just to remind, this is actually from the Palm trial in 2018 2019, and this is the second to last paragraph, and they just highlighted the challenges of actually treating and doing trials in places where this happened. And they talk about regional violence, mistrust of the government, mistrust of the Ebola response, unstable electrical power grid, and the fact that their trial was actually interrupted and temporarily closed because they were actually threatened by the militia in that area. So it's a very contrasting idea of what is available and what you're heading towards. And that was in 2018, but this is from the 26th of May. This report that same sort of similar distrust of the health system and services. So just in summary, we are going to see probably a lot more filoviruses because these are human population, more contact with the environment, and the bats are there. They are very happy to host their viruses, and it's not only about when we're acutely unwell with it, but what you do afterwards, the home afterwards, the long-term care of patients and other features that are going forward. I'm going to leave you with these lovely pictures from the Ministry of Health in Uganda about preventing Ebola through means that people can actually understand.